Good afternoon. Here are my disclosures. Of course, I would say the heart is more important, but maybe we'll go with the lungs, I don't know. So anyway, the one thing to keep in mind is a lot of what we'll be talking about is off-label, so I'll make a point to mention that. But the most important disclosure, especially for Dr. Valentine, is that I'm just a heart doctor. Actually, I'm a simple-minded heart doctor, so I may not get too complicated or complex slides. Now, I don't know if Saraf is here yet. Evidently, we have some of the same slides, so I'm going to try to make sure we don't duplicate. So a lot of the slides, I won't really show them. But when we talked about percutaneous mechanical devices and ECLS in cardiogenic shock, certainly there has been an explosion in its use in the last 10 years. Most hospitals will use preferentially one modality as opposed to having all of them available. The outcomes are variable, and what I'm going to try to show you is that the outcomes go from very poor to excellent depending on the condition of the patient, and these devices, whatever you want to use, provides excellent support when initiated on time. The issue is, what is cardiogenic shock, and that's what I'm talking about. If you look at the definition textbooks and even some of the trials that I'm going to be presented, the definition is usually the same. So it's a mean arterial pressure of less than 90, CI of less than 2.2, LVEDP greater than 18, or RVEDP greater than 10, 15, so wedge or RA pressure. Well, that's 90% of the patients I see in clinic. So how come they're not in cardiogenic shock? Well, because you have to have clinical signs of hypoperfusion. So the patient is cold, decreased urine output, altered mental status. The best analogy to this is that you can have somebody that is perfectly healthy with an acute MI or myocarditis and only have a wedge of 18. On the other hand, you have somebody who has had heart failure for 20 years, and they're walking around with a wedge of 40, and they're doing perfectly fine. So it makes a big difference when you're using the definition. Just make sure that they have clinical signs of or symptoms of hypoperfusion. And then all this is derived from the Killip and Forrester classification for the 1970s in acute MI, and what these devices should be used for is the patients who are cold and wet. So the patients in cardiogenic shock that have severe pulmonary congestion and severe hypoperfusion, not only by the numbers you get, but also clinically. And then this is what we have to deal with when we're dealing with patients in cardiogenic shock. There's not one single condition that we can say, well, we're going to tackle this and the patient is going to get better. But when the patients get congestion, decreased cardiac output, everything becomes a vicious cycle. And some of these devices, what they do is that they break that cycle. And you'll be surprised how just with providing a little bit of extra flow, a little bit of extra blood pressure, the patients get better, because not only you're improving the hemodynamics, but you're also improving the catecholamines, improving the inflammatory markers on these patients who are very sick. So what are the goals of mechanical circulatory support or percutaneous MCS in cardiogenic shock? Well, you want to maintain organ perfusion, and that should be priority number one. You want to make sure they have good cardiac output. You want to improve the coronary perfusion. You want to reduce the myocardial oxygen demand, and you want to decrease the inflammatory response that is massive in these patients, including neurohormones. So how do we do that? Well, that's what we're going to talk about in the next few slides. The ideal support device, I know that Dr. Saraf is going to talk about pressure volume loops, but the ideal device should be, assuming this is a patient in cardiogenic shock, that the very high EDP, so high preload, very high afterload. Contractility may be altered as well. So what you want to do is move that to the left. You're supporting the patient, there's flow through the device, but you're really decreasing the preload, but also decreasing the afterload of the ventricle without really changing the contractility that much. That looks nice. That means that, you know, the potential energy on the ventricle, so myocardial oxygen demand is decreased and whatever. And I'm here to tell you that there's no ideal support device yet. So that's it. I'm done. No. I'm going to talk a little bit about each one of these, and you know I don't want to overlap with Dr. Saraf talk, but I start with the oldest one, the balloon pump. Then we'll move to the direct LV unloading. Basically, the Impellas, the heart-made PHP is not available in the U.S. Then left atrial unloading, that's the TandemHeart, and a couple of slides about RV support, and then talk about VA ECMO and a total support. So the intra-aortic balloon pump has been around for over 30 years. It's easy to implant. You can do it at the bedside. You don't need fluoro. You can do it blindly. It's a 7.5 to 8 French femoral or axillary. And Sarah was going to talk about the pressure volume loop, so ignore that. But bottom line is decreases your afterload, increases your coronary perfusion, decreases myocardial oxygen consumption, and on average increases your cardiac output by about a liter or so. And that's certainly variable. When you have somebody who is really ill, then that extra liter of cardiac output is really important. In some patients, it may not make a difference. And also, it works better in patients who have very high afterload. So in patients who have a very vasoconstricted from bad heart failure, true cardiogenic shock, is actually, so those are the patients who do the best with a balloon pump. And you can see it right away as you turn it on and you see this big augmentation, then you know the patient is getting benefit from the balloon pump. So there have been, what's the data available? Well, there has been multiple observational and meta-analysis, mostly in acute MI. So going through a few of those, TACTICS was a study done with balloon pump plus fibrinolysis versus fibrinolysis alone, and certainly that was using the balloon pump in those patients was beneficial, especially if the patient was in shock. In the shock trial, which was AMI plus PCI, really there was no change in outcome between balloon pump and no balloon pump, but the patients who had a balloon pump had the better unloading, meaning the pressures were a little bit lower, the BMP was better. And then this was a larger trial, the IABP Shock 2 trial. This is patient with acute MI and cardiogenic shock. It actually failed to meet the endpoint, but the population wasn't ill enough, and there was a low use of balloon pump pre-PCI. So the data is not robust, but we know it works. Sometimes the problem is that the patients who really need it don't go on the trial. You will never be at the bedside and say, I think this patient needs a balloon pump. Can you sign here whether you get it or not? No, we go ahead and do it. So really there's no data. Same way that there's no data to use inotropes in cardiogenic shock because you can't really, it's not ethical to withhold therapy. And most of these trials, they actually had a large crossover in the patients who weren't supposed to get the balloon pump, for example, that eventually got the balloon pump. There's been some other non-ACS related use of balloon pump, usually mainly cardiogenic shock in small single centers. Some of those as a bridge to transplant. The mean, this is a small story, I don't remember from where, but mean duration 21 plus minus 16 days, 80% of them survived to transplantation. There's been a lot of talk about this axillary balloon pump. It's been done in a couple of centers. The first study was published out of Houston. So the median was 18 days, 92% survived to transplant, and more importantly was safe to implant. And then just recently there were two papers about using this mega balloon pump, which is as opposed to using the 40 cc's, using the 50 cc's optical balloon pump with an average increase in cardiac output by 1.6 liters per minute, a CI of about 0.8. So that's actually as good as some of the smaller devices. And there was a 73% survival in all the patients. This is a single center, and the patients could be transplanted. Either they were bridged to durable VATs or they got better and got weaned. So actually pretty good. The way to look at the balloon pump is something like this. Supposed to an injection, imagine a balloon pump. This should keep you going while I'm on vacation. So you can do the balloon pump, figure out what you're going to do with the patient, what you have available, and then move to the next step. So the second one is the LV unloading, in this case the Impella. So it's implanted, it's a continuous non-pulsatile extra flow mounted on a pigtail catheter, could be implanted usually femoral, could be implanted subclavian, especially the bigger devices. We have 2.5, the CP, which provides about 3.5 liters of flow per minute, and the LP, this is certainly surgical implantation with up to 5 liters per minute. If you look at the pressure, oops, I wasn't going to talk about that. But bottom line is decreases the wedge, it increases your cardiac output and decreases your myocardial oxygen consumption. And in fact, just to mention a little bit, this looks more like the ideal device for somebody in cardiogenic shock, although in order to be ideal, I think the preload should still be somewhat lower. There are a few studies, and I know Saraf is going to talk in a few of those. I hope this doesn't fall. But make sure you get a video, though, if he does, for my daughter. So if you look at the some of the studies, the PROTECT 2 trial was Impella 2.5 versus balloon pump in high-risk PCI, and using the Impella over the balloon pump led to improved hemodynamics, but the outcomes were exactly the same. If you look at the ISR shock, was Impella, again, 2.5 and versus balloon pump. The Impella improved the hemodynamics sooner as opposed to the balloon pump, but by 4 hours they were quite similar. And then the IMPRESS trial, this one uses the bigger pump, the 3.5 liters versus balloon pump, and this was acute MI and cardiogenic shock. And the 30-day mortality was about the same in both groups. However, the Impella is relatively easy to implant and manage. It's easy to wean. There's better data for PCI support as opposed to cardiogenic shock. The 5.0 may provide better support, and you can do an axillary graft for prolonged support. And couple of considerations: it can dislodge easily. There could be a fair amount of hemolysis that eventually can lead to either kidney failure or anemia or other problems. And my concern sometimes is that it may not provide the support that you need. Because if you think about it, if you have a ventricle that is ejecting normally, then it's fine. You can overcome the Impella. However, if you have a ventricle that is very weak, that one of those almost stand still, well, whatever flow you get is only the Impella. So getting 3 liters of fluid or 3 liters of cardiac output when you had 3 before may not be a good trade-off. And the reason for that is sometimes the ventricle can't generate as much pressure to open the aortic valve. So whatever you get through the Impella, it is the cardiac output. And sometimes that may be enough, sometimes may not. Sometimes you need to maybe add inotropes or something, depending on the condition. So just keep that in mind. And when you look at the TandemHeart, the LA to femoral, the left atrium to femoral artery bypass, it can actually provide up to 5 liters per minute of flow. Requires a transseptal puncture with relatively big catheters. certainly it leads to, of the devices that we've shown, leads to most of the LV unloading, decreased preload, decreased wall stress and filling pressures, decreased myocardial oxygen consumption. It still doesn't look like the ideal device based on the pressure volume loops. But anyways, it's a good device to unload the ventricle in the situation, when the situation really requires. So when you look at TandemHearts and the data available, you look at the TandemHearts in acute MI. So it actually improves CI, PA pressures, wedge, but the 30 days mortality, again, was about the same. There was this was published in the mid-2000s, so the TandemHeart investigator group. So this was against a balloon pump, and there was a significant improvement in CI, wedge, but mortality was unchanged. Maybe a trend towards higher mortality in TandemHearts, but really not statistically significant. I think the best study we have so far is the Texas Heart Study with 80 patients with acute MI and cardiogenic shock. 50% of them were getting CPR at the time of the TandemHeart implantation. The 30-day and 6-month mortality was 40 and 45%. So that means if you really survive the acute episode, you do well over time. So this was done in 2011 or so. So some of the considerations about the TandemHeart is technically challenging. You have to do a transeptal puncture to implant. There's more vascular complications, more complications related to punctures, and I'm pretty sure Saraf will have more information about that. The management of it can be somewhat complex. And there's this device, the TandemHeart Life, that includes an oxygenator that is approved for VA ECMO for up to 6 hours. So it will be a device that may be ideal to get somebody transferred in cardiogenic shock, transferred to a tertiary facility. If you search TandemHeart on Google, this is what comes up. It's a man with a heart on a tandem bike. So I thought that was cute. But the right ventricular support devices, so we have tandems with it's a dual lumen cannula, so it goes through the IJ, plays in the pulmonary artery. So the way I look at this is like a bypass of the right ventricle. So it will be, somebody's really struggling with right ventricular dysfunction, this will be the ideal device. These Impella RP can also help the patients with RV dysfunction. Same principle coming from the groin, the rotor is reversed and then placed in the main pulmonary artery. So both are used in patients who have RV dysfunction for whatever reason. In fact, we've been using it relatively, not often, but I think the main application will be post-LVAD. I don't know if you can see the X-ray as well, but this is a patient with a HeartMate. This is a HeartMate, and then you can see the Protect Duo coming from the neck. This is a patient who has severe RV dysfunction post-LVAD. This is a patient with an Impella RP, again, another HeartMate 2, severe RV dysfunction, and ended up with an Impella RP. And I think these Protect Duo stayed in place for 3 to 4 days. These Impella RP, I think, maybe in 3-4 days, right ventricle improved enough that could come out. So these devices are used mostly post-LVAD. Or another indication will be RV dysfunction post-MI, sometimes post-transplant, especially in patients who have severe pulmonary hypertension going into transplant, at least until the right ventricle is conditioned, and allows recovery and or training of the RV. In situations like post-LVAD, it may or may not recover. Usually post-MI and post-transplant, the RV usually recovers. So you can bridge them a little bit longer as the right ventricle tends to come back. So now VA ECMO, that's what I guess you're here for. So it's an RA to systemic artery assist device. It provides biventricular pressure and volume onloading. It's a total respiratory and circulatory support. It restores circulation quickly. The problem is that it not only decreases your myocardial oxygen consumption, wall stress, and filling pressures, and decrease your preload, but eventually can lead to increase in afterload. And that increase in afterload that you see here might be detrimental to a ventricle that is already suffering. There are multiple small and single-center studies. The best outcomes is in patients with fulminant myocarditis, where there's a 72% hospital discharge, but there was a 70% major complications. So yeah, you can use them, and you know that this is going to get better, so you can bridge the patient to recovery. If you look at data or some of the studies on, and I only pick a few, in acute MI with cardiogenic shock, not requiring CPR, the 47 of them were alive at discharge. 38% were alive at 1 year. Some of the data out of the ELSO database, and this is only 295 patients, 75% acute MI, and these were patients receiving CPR. There was a 27% survival. So most studies are done with peripheral ECMO. So this leads to a quick restoration of output and perfusion. The increase in afterload is problematic when peripheral cannulate, especially if the ventricular function is poor, because it can lead to increase in wedge pressure, lung congestion, and at that point you need to think about unloading the LV or LA for this matter. And you can use inotropes, balloon pumps, Impella, Tandem. You can use even use an LV vent. These are just a few examples of the patients who have been on ECMO for. This is a patient who's actually now in the unit with peripheral ECMO and bad hypertrophy, so already having some lung congestion. She responded to just diuresis. And this is really an extreme case where there's no lung left from consolidation. So you want to prevent this. As soon as you see this, is the time to either they respond to diuretics, you need to switch them to something else, or use something else to unload the left ventricle. And then the other potential complication, and this is another patient who's in the hospital right now, is that if you take the heart out of the equation, minimal blood flow through the heart is already bypassed, then this happens. Blood is stagnant in there. In fact, I don't know if you can see it that well, but there's a big clot in the left ventricle there, and the aortic valve is not first of all, it's not opening, and it's full of clots. So the whole ascending aorta is thrombosed. So that's really a concern, and something that we really take seriously, and is really a major complication. That's when central ECMO comes into play. So it's like MCS via sternotomy. It's indicated when the peripheral system or peripheral ECMO is unable to generate adequate hemodynamic support, or you're having complications with your peripheral ECMO. It prevents ECMO lungs or lung congestion. It unloads the ventricle even further. You can do several configurations on central ECMO. I'm just a heart doctor, not a surgeon, but you can do LV support, so LA or LV to proximal aorta, RV support, so right atrium to PA, just bypassing the right ventricle, or by V support, RA to proximal aorta, and that really takes the heart out of the equation. The question is, what are you going to do next? There's a few of the devices. I see the vendors outside, and the main complications is bleeding, vascular complications, infection, thrombosis, hemolysis, neurological events, HIT, and so on. But really, it's a good technology when applied to the right patient. And then I found this also. I would like to help, but you need ECMO, not ELMO. So. if you look at the cardiac runs done in the U.S., certainly there, as I said at the beginning, there's been an explosion in the last 10 years or so. From I think in 2010 they were about 200-300 to over 3,000 cardiac runs last year. The interesting thing is that the outcomes is actually stayed exactly the same. So survival is somewhere in the low 40s, somewhere between 42 and 45%. However, when you break that down within the diagnosis for implantation, you see that in patients who have myocarditis, high likelihood of recovery, the survival is actually better, 60%, as opposed to the patient who gets on ECMO where they're getting cardiac CPR, which is only 33%. You can say the outcome is bad, but maybe your patient is one of the ones of the three that will benefit from that. So who really benefits from ECMO, cardiac-wise? Lung-wise, don't know much. I'm not intelligent enough to be a pulmonologist. But so patients in cardiogenic shock, myocarditis, AMI, or acute MI with or without CPR, patients in the midst of a resuscitation attempt on post-cardiotomy. The point I want to make is that the patient has to be alive in order to survive ECMO. So we don't really use ECMO to revive somebody. We're really just bridge the patient to something else. And then you want to bridge the patient to really to either a durable device or transplant or recovery. The circulation is going to be restored quickly, preventing end organ damage, but it's really not for the treatment of end organ damage. So once you have end organ damage, then might be too late. Whether we can, agree or disagree as to what degree of end organ damage is acceptable, and I'll show you a couple of slides. And then you want to define the goals of treatment early in the process. So if you look at the SAFE, this is a SAFE investigator. So they came up with an equation based on all the patients placed on ECMO, on VA ECMO, cardiac ECMO in Australia, and a few things pan out that are associated with poor outcome. Patients who already have chronic kidney failure, so those patients don't do too well. Patients who have been intubated for a while before they get on ECMO. Even if you've been intubated for over 11 hours, your outcome is actually worse than the patients who came from the streets or acute or soon after cardiogenic shock. And then the patients who already have end organ failure. So the patients who have liver failure, CNS dysfunction, or acute renal failure, the outcome is also poor. If you look at, they came up with a score system, and I think goes from -10 or less than -10 to 10 maybe. But if the more comorbidities you have, the worse your outcome is. And certainly if you have kidney dysfunction, liver dysfunction, your outcome just by that is less than 30%. So they came up with a formula and an equation. You can find it online. It's called safescore.com. And that will give you an idea. These are the parameters that they take. And certainly if you look at these outcomes here, or this box here, as soon as you click liver failure, it's already outcome is less than 20%. If you put liver failure and acute renal failure, then it's even worse than that. So just that gives you an idea as to when these patients need to go on ECMO. So to summarize this part, there's VA ECMO is the ultimate resuscitation. There's multiple configurations. You have to take into account the high complication rate. You want to define goals of therapy early, and the management of these devices is complex. And then patient selection and timing is everything. If you putting all these together, what I said today, when you have somebody in cardiogenic shock and you already treat the reversible causes, or you want to bridge them with something to treat the reversible causes. It could be inotropic agents, balloon pump, Impella, TandemHeart, VA ECMO. I mean, there's many patients who come in, they're really sick, you start a little bit of dobutamine, they feel like $1 million. Well, that patient probably doesn't need ECMO unless you see some other changes. And then some patients who from the get-go, I think you should go to VA ECMO. That's how profound their heart failure and cardiogenic shock is. And then as soon as you improve hemodynamics, so lactic acid, renal function, LFTs, urine output, and so on, then you try to consider either are we winning or are we doing something else? And for us, that something else could be waiting for a transplant, which doesn't realistically happen in a timely manner, or going for a left ventricular assist device. This is just a summary. More importantly, to bring to your attention that the Impella, Tandem, and ECMO certainly bring peripheral perfusion fast, more so than what the balloon pump is, but never underestimate the oldest one. It's all in the eye of the beholder, right? This is the first snowman that my kids stuff looks good, right? But if you look at that, you think that that's great and wow, they did a good job. Well, this is the snowman. So it's all depends on the eyes that you look at it. So just remember that a lot of the patients might just do okay with a balloon pump. Some of them might need to go all the way to VA ECMO. So to summarize, never underestimate the value of a balloon pump. All devices work in the short term for the right patient. So ECMO provides the most support. If you want to look at support, certainly goes from ECMO all the way. I forgot, should have put in there inotropes. It's a center-specific. Patient selection is everything. Early intervention is a must. So sometimes you have to do it at 2 in the morning as opposed to wait to be 6 in the morning. And you want to define the goals of therapies early. So are we talking about recovery or bridge? If there's no recovery, what are you going to do? You can bridge somebody to recovery, but then what's the next step? Just always keep that in mind. This is an editorial I wrote for that TandemHeart paper, and what I wrote then certainly applies to this technology. It is important to define futility and discuss end-of-life issues with patients and their families. This type of technology can prolong dying as opposed to alleviating suffering or improving survival.